Hi, I'm Dr. Michael Gordon, the Chief Medical Officer for the HonorHealth Research Institute in Scottsdale, Arizona. I'm joined today for our latest podcast, Innovation Insights, by my friend and colleague, Dr. Rahul Doshi, who is the Chief of our electrophysiology program at HonorHealth and a professor of clinical medicine at the University of Arizona College of Medicine, Phoenix. Dr. Doshi, thanks so much for joining us today.
Well, Dr. Gordon, thanks for having me. It's an absolute pleasure to be here.
And our topic for today, good, bad, or indifferent, is something that every medical student at some point has to deal with, and that's atrial fibrillation. And I thought we could start off maybe by just talking a little bit because, people who are watching this podcast may not be familiar with it, but can you share with our audience what exactly is atrial fibrillation and why do we consider it to be one of those dangerous things that people don't know about?
It's a great question, and of course makes me very happy that every medical student has to learn about this and deal with this, but I would actually say that every person needs to know about this. This is by far the most common arrhythmia in the world. I'm sure most of our listeners, certainly within our patient population, either know someone with atrial fibrillation or themselves have it. So yes, this is incredibly common. And it is, of course, an arrhythmia, an electrical disturbance of the heart. What's unique about atrial fibrillation, it's associated with all kinds of things that we usually associate any arrhythmia with. Symptoms of fluttering or palpitations, symptoms of other things we think about in heart disease, such as chest pain or difficulty breathing. But it actually varies tremendously how people present. People can sometimes feel it, some people don't feel it. Some people feel palpitations, some people don't. And this is what makes it rather challenging because the symptom complex is so varied, yet it's so prevalent and it's associated with a couple nasty things. Nasty as a cardiovascular practitioner, the two things that I'm very scared about, always scared about, is stroke and heart failure. And atrial fibrillation dramatically increases the risk of both of these things. So for a long time, and when you and I were in medical school, it was like, oh, it's okay. You can live with atrial fibrillation. But what we've learned in the last 25 to 30 years is that this is actually something that's associated with a lot of bad things, including an overall risk of mortality. And so very important to recognize, very important to treat.
I recall, to your point about medical school, that old depiction of the atrium, the top chamber of the heart, just kind of fibrillating or looking like, what is it they call it, a basket of worms. And of course, your point about stroke relates to the fact that when blood is not being ejected formally, blood clots can actually form on that inside. And that's what can be ejected and lead to stroke and really bad outcomes.
You're absolutely right. And so while this is a rapid rhythm of the upper chambers of the heart. I mean, we all remember high school biology, right? The upper chambers fill up with blood, squeeze to load the main pumping chambers, and then the lower chambers squeeze blood to the body. The left upper chamber in particular, the left atrium, when it is in fibrillation, just as you said, is just not contracting in an organized fashion. That fibrillation, as you said, the sort of almost a quivering, if you will, of the heart muscle. But that leads to blood stasis in an otherwise low pressure system. And if blood is static, if blood's not moving vigorously, blood can pool and then it can clot. And then if that clot gets dislodged, that can go to the rest of the body, including the brain, which is, of course, what a stroke is when it's associated with a thromboembolism or a blood clot coming from the heart.
So it's so interesting because we think about the heart as always contracting, always moving. In contrast, we tell patients if you are sedentary and you're sitting on an airplane or in a car a long time, you might develop blood clots in your legs. It's important for people to understand as we talk about management strategies that fibrillating chamber is just as if it's just not doing anything. And that's where those clots can develop.
It's a perfect analogy, actually, because it's exactly the same process. But the other thing that's important about atrial fibrillation is because those upper chambers aren't squeezing, the main pumping chambers aren't getting loaded with blood, if you will. And so between that and just simply the hallmark of atrial fibrillation is this irregular rhythm, right? We classically say irregularly irregular. There's no rhyme or reason for how the heart rate or pattern is. And that in itself, not loading the lower chambers and being irregular, leads to a decrease in cardiac function. So the heart's not working as efficiently as it should. And that's the reason why the heart can actually get weak associated with atrial fibrillation. And thus heart failure is the other big problem. And heart failure is the largest killer in all of cardiovascular medicine. So it's really important that we target these things upstream that can lead to poor outcomes downstream.
So it almost sounds like atrial fibrillation can present as everything in the cardiovascular world. You mentioned palpitations. I imagine shortness of breath. What are some of the other signs and symptoms that patients may look for or may feel and should send a signal to say, I better see my doctor because?
I mean, it's so difficult because, as you say, classical symptoms, new onset atrial fibrillation, feeling that fluttering, the palpitations, feeling like I just can't get enough wind or just not get enough oxygen, feeling short of breath. Sometimes patients experience chest pain associated with atrial fibrillation, and it has nothing to do with blockages in the arteries. It's just a result of the heart not working as efficient. But sometimes it's very vague. Sometimes folks can just present with just kind of feeling off, just a little bit fatigued, and unfortunately, some patients are completely asymptomatic. And that's where that dangerous risk of stroke really comes in, because a significant portion of patients present as their first manifestation or their first diagnosis of atrial fibrillation, unfortunately, with stroke. And that's something that we have a lot of treatment that we can direct to mitigate those risks. And so it's really important to make a diagnosis.
So I guess I always understood that the risk of stroke went highest when a fibrillating atrium suddenly converted back to its normal function and squeezed and sent a blood clot out. Is it realistic to think that patients at various different times may or may not be in fibrillation?
It's a very complicated question, actually. Traditionally, we do characterize atrial fibrillation in different subtypes, right? We have folks with intermittent atrial fibrillation, what we call paroxysmal. We have folks that remain in atrial fibrillation for a period of time, by definition more than a week and less than a year. We call that persistent. And it's really more related to continuous atrial fibrillation that we need to do something to convert the patient back to normal rhythm. And then we have folks who we consider who are in atrial fibrillation for really long periods of time, and if you stop management to control the rhythm, we call that permanent. Okay, so you'd think that that risk might increase with the duration of atrial fibrillation. You might think, and we were all classically taught a long time ago, that just as you say, someone's in fibrillation, that blood clot occurs, and then restores sinus rhythm, and then it squeezes out that clot. And it turns out that's actually not the case. We have good data from all these monitoring studies, since we have so many sophisticated ways of monitoring patients now, that the relationship of atrial fibrillation, either onset or termination, is not necessarily associated with that incident of stroke. So it's very complicated. It also turns out that Afib is a disease, and so it's associated with a lot of things like just having this inflammatory state or this procoagulant state, the tendency to make blood clots. And that's why we actually use risk factors to really determine, regardless of the type of atrial fibrillation, what the patient's overall risk is. And those risk factors, there are many, but they certainly include some very simple basic things, such as your age. And as you can imagine, the older patients have a higher risk. There are some particular diseases that are associated with a very significant risk: diabetes, hypertension, which are of course very, very common, and heart failure, as we talked about. And then of course, if you've had a history of stroke, that's a very significant risk factor. Now, interestingly enough, speaking of risk factors, since one of the things that we really strive to maintain is the being equally aggressive at treating women as we do men, right? We do know that across the country, across the world, there are discrepancies in healthcare between men and women. And atrial fibrillation is one of those diseases that actually we should really focus on women, because just being female is an associated risk of having a stroke.
I didn't know that. It's interesting. I guess so I am always a little bit bemused when you see the advertisements for these little toys that you can append to your phone and put your thumbs on and look to get your rhythm strip on. But in terms of diagnosing atrial fibrillation, in terms of screening for it, if you had somebody who you thought was at high risk, is there a paradigm that you follow in terms of the frequency of assessments or how you do that?
Absolutely. As you can imagine, we have a full spectrum, just like any disease is a full spectrum of disease. And so you can imagine that goes from intermittent monitoring to continuous monitoring. And within that intermittent monitoring space, there's all kinds of technologies. And this is what's actually really powerful when we're talking about diagnosing patients and trying to diagnose patients early so that we can mitigate their risks and their outcomes are actually better, of course, and that's been demonstrated. So gone are the days, you and I remember when the type of monitors that people wore were these big giant things that looked like a portable 8-track player that was hooked up to wires and electrodes, and it was just very cumbersome, and it turns out that they only monitored patients for a day or two. So I can tell you as an electrophysiologist, anytime I can monitor somebody short term, they never have what I'm interested in at that time, right? But we have all kinds of monitors now, ranging from continuous monitoring in high-risk patients, patients who have an important treatment algorithm dependent on whether they have any recurrence, or patients that are completely asymptomatic and they just need that. We have implantable devices called loop recorders that, much like any other implantable cardiac device like pacemakers, we can continuously monitor atrial fibrillation. And in fact, the patients don't even have to think about it. These devices talk remotely to our device clinics and we can monitor them from afar. We have all kinds of new wearable technology, though, some of which we prescribe. Patch monitors are a mainstay of treatment, and in somebody that we're trying to either confirm a diagnosis or determine how much atrial fibrillation they're having, we typically prescribe them in their office. But you mentioned, and I'm so glad you did, these toys. Well, there's toys like the AliveCore, which is the device you were describing, is a medical grade ECG. The data has been very well validated that it actually can collect a full ECG quite accurately. And all these wearable technologies, these sort of ideas of what we call body computing, right, where the patients are actually taking control of their own health and actually going to direct-to-consumer products, such as an Apple Watch paired with your iPhone, that actually can monitor folks and with a fairly good accuracy actually diagnose atrial fibrillation, or at least make that suggestion that you should see a physician. Interesting, we've been doing monitoring studies for a long time. The Apple Heart Study, which validated actually an older algorithm before the Apple Watch was able to record an ECG, is actually incredibly sensitive and specific and is the largest monitoring study, almost 500,000 patients.
Wow.
Yes, ever done. And so you can imagine the power that not just this data that we're getting and the insights that we can make from it, but the fact that actually every one of our patients can actually take control of their own health and actually monitor themselves. And it's incredibly powerful.
It's clearly one of the evolving strategic opportunities as we move into this world of AI-dominated health, where that type of accuracy allows you to be confident with your own personal screening in that regard. But it sounds like at the end, no matter what you're doing, the important message is listen to your heart. And if you have symptoms, don't ignore them. See your primary care physician, see a cardiologist, and get into a program that can effectively screen and diagnose what could be a potentially life-altering disorder.
You're exactly right. I could not have said it better myself. And in fact, it's one of the things that from a program standpoint here at HonorHealth, we're absolutely focused on. Because, as you stated, this is so common and everyone is involved in the treatment of folks with atrial fibrillation. We actually have created a paradigm shift in a way where folks with a new diagnosis of atrial fibrillation, whether they're coming from the cardiologist's office or their general practitioner's office, or even from the ER and urgent care, a new diagnosis can actually be funneled directly to our atrial fibrillation clinics that we have throughout the valley to allow patients to actually see an arrhythmia specialist earlier than later, because the bad news is that atrial fibrillation is incredibly common. And I say all the time that it's the gift that keeps on giving, right? It is something that's there and you have to be cognizant of it. But the really good part of this is that we have so many different treatment modalities now that if we can get patients and see them earlier, we can offer a whole potential myriad of therapies that in some cases are life-threatening or life-saving, I should say.
Well, most definitely before they walk in the door with a stroke, because
Absolutely.
that becomes really problematic. So I guess lesson 2 or point 2 is HonorHealth is coming to you wherever you are in the valley to be able to deliver this very important care. You mentioned risk factors. Are there genetic risks? As an oncologist, we're always talking about the genetic risk element. Are there lifestyle risks, things that patients can change? Can you talk to us a little about that?
Absolutely. And so the short answer for whether there are genetic components, as with so many things we're learning in medicine, is of course the answer is yes. We actually know that many of the traditionally what we think of as genetically inherited arrhythmia disorders, these tend to involve proteins that on the cellular level are involved with how electrolytes or ions move between the cell. And we have these things well described for classical arrhythmias that we know are genetically inherited. And it turns out that all of these same channelopathies, if you will, these disorders of these ion channels, are also associated with atrial fibrillation. But there's so many more. And in fact, because there are so many different factors that are genetically inherited or may relate to a genetic risk, and as you would know better than I would, that when you have such a prevalent disease, it's hard to discern what is the particular bad actor. There are many. It's multifactorial, but there's absolutely a genetic component to this. If you have one first-degree relative with atrial fibrillation, you have a 40% chance of being diagnosed with atrial fibrillation in your lifetime. If you have 2 first-degree relatives, it's 70%. And so absolutely a familial component. We obviously can't do anything about our genetics, but we can do something about risk factors or lifestyle modifications, as you mentioned, and you're spot on again. Certainly, there are this obvious things that if you have an underlying disease, you treat the disease. And yes, there are all the cardiac disorders, people with coronary artery disease, people with hypertension or hypertensive heart disease, people with valvular disease. Yes, all these things are associated with atrial fibrillation. But it's more than that. There are absolute lifestyle modifications that we know are very powerful. On the disease side, for example, thyroid disease can be associated with atrial fibrillation, so very important to treat. Something that's underdiagnosed but incredibly prevalent, sleep apnea, sleep disordered breathing, absolutely associated with atrial fibrillation, and it's very important to treat because if you don't, any treatment that we do is less effective. There are very obvious things. We talk about being heart healthy, and that involves, of course, diet and exercise. And yes, those are powerful at decreasing your risk of having atrial fibrillation. The exercise thing in extreme is an interesting sort of thing that we can maybe talk about. But then some other things from for example, alcohol consumption, absolutely associated with atrial fibrillation. There is something called the holiday heart syndrome when somebody during the holiday or a binge drinking episode can be associated acutely with atrial fibrillation, even in younger folks, but even steady alcohol consumption is associated with atrial fibrillation. Stress has been associated with atrial fibrillation, and in fact, stress modification has been shown to decrease atrial fibrillation. And so there's a whole host of things. Some of them are very common sense, but some of them are a little bit more deeper dives for sure.
So it's higher risk of atrial fibrillation during this coalescence of football season and baseball season as we're getting closer. As an aside to it, though, it's interesting that you mentioned the sleep apnea. We're in a world where we have a host of new drugs designed to enable people who are overweight or obese to lose weight. And I would presume that for many who have associated sleep apnea, they'll see improvements in their sleep apnea in that regard. Do you hold out hope that the incidence of atrial fibrillation will reduce as we see improvements in some of those outcomes?
I think in certain populations for certain. And there's no doubt that obesity or morbid obesity is associated with atrial fibrillation, and that's even independent of sleep disordered breathing or sleep apnea. And so, yes, treating the obesity epidemic will have a positive effect on all cardiovascular disease, and that should include atrial fibrillation. Now, do we have good data as far as what that disease course will be 20, 30, 40 years down the road? We don't know, but I will tell you that the patients or a patient population that we see with atrial fibrillation at a very young age is exactly that population. And absolutely, treatment of the more severe types or morbid obesity is associated with decreased arrhythmia, higher success of our treatment strategies, absolutely no doubt.
And has that been borne out in the bariatrics literature? So very, very interesting. And of course, again, the intertwining of so many of our coalesced research programs because of our bariatrics program and cardiovascular.
That is incredibly well stated. Obviously, the partnership that we have in electrophysiology, being the subspecialty within cardiology that treats these disorders, with our cardiology colleagues, of course, but it's so much more than that. We have partnerships, relationships with bariatric clinic, with the hypertension clinic, with, of course, neurology. It just, that multidisciplinary approach is absolutely essential at treating atrial fibrillation because it's a multifactorial disease.
And you've been talking a lot about how there are a range of cardiovascular diagnoses that can be associated with AFib. As you begin to work towards diagnosing certain diseases like coronary artery disease earlier, do you expect to see a reduction with effective treatment of AFib, or is it just a destiny issue? If you have coronary artery disease, regardless of your age, you will eventually have a higher risk of AFib?
I'm not sure that I know. There is no doubt that coronary disease does increase the risk of atrial fibrillation. We see that classically with more advanced disease, and so early in these treatment algorithms, we sort of almost separate the two. And in fact, there are some other structural heart disease elements that have a much higher risk. But you would think that overall, decreasing cardiovascular disease in general drives the incidence of all these things down. And that's certainly the case for coronary disease, and that's certainly the case for atrial fibrillation.
And we're certainly appreciating that earlier intervention in terms of things like aortic valve management or management of aortic valve disease can have an impact on just survival. And I presume that some of that survival is going to be related to outcomes with regard to AFib.
Once again, spot on. It has actually been demonstrated that earlier intervention in the function of treating valvular heart disease, such as aortic stenosis, a narrowed aortic valve, is associated with decreased risk of things like atrial fibrillation. And so, yes, treating patients upstream is always associated, it seems, in cardiovascular medicine with improved long-term benefits. I mentioned that, when you and I were in medical school, we didn't have that data with atrial fibrillation. We do now, right? There is good randomized control trial data, the best kind of data that demonstrates that early intervention for atrial fibrillation is associated with good stuff like prolonged survival. And so, yep.
That's the best stuff as an oncologist.
So absolutely, right? The ultimate and hard endpoint, right? So we are now sort of charged to recognize folks earlier and actually implement treatment strategies earlier.
And it's consistent with that you can turn on your TV and see advertisements and commercials that more focus on diagnosis of AFib, the symptoms of AFib, towards a goal of treatment, but also a significant goal of awareness, which I think is one of the biggest issues. But that's a good segue to, so what are the latest advances with regard to atrial fibrillation? Because I remember as a resident, it was digoxin, and digoxin.
So for those of you who don't know, digoxin is a very old medicine.
Not that I'm very old,
no,
but
it was actually one of the first medicines ever used for pharmaceutical use, right? Yeah. That just basically slows the heart rate in atrial fibrillation, and that's all it does. And we thought that was enough, and then we thought that, well, no, we know about the risk of stroke, so we have to put folks on blood thinners. And that used to mean Coumadin or warfarin, which is affectionately known as rat poison, right? And so, and it's being a little facetious. It's an incredibly powerful benefit, but is associated with risks. Of course, every blood thinner is associated with the risk of bleeding, and of course the management to regulate those levels, which was the difficult thing with warfarin. So as you know, there have been a lot of advancements pretty much across the board. And so we talked a little bit about diagnostics. So certainly the diagnostic techniques that we have to make a diagnosis, the type of monitoring strategies that we have exploded. And that's incredibly powerful. So we can make the diagnosis earlier, and we can identify the patients who need a more active treatment strategy. Okay, treatment strategy. Interestingly enough, even over my career, which is now in electrophysiology 25 years, there's not been a lot of advancements at drugs to treat atrial fibrillation, meaning keep folks in normal rhythm. But what there has been are huge advancements in the technologies for a rhythm control strategy called catheter ablation, where we go into the heart with catheters and actually eliminate the areas that are driving the atrial fibrillation. Typically, this is an outpatient catheter-based procedure, which has a much, much higher, easily 2 times success rate compared to drug therapy. And as this procedure has gotten more and more efficacious and more safe, the guidelines keep going toward more and more earlier intervention, less symptomatic, to the point where this is almost becoming first-line therapy. And it just keeps moving in that direction. And it's one of the things also to highlight that it's, being part of these ablation strategies and innovations in these ablation strategies, there is a great deal of advancements in technology, and I'm very proud to say that we've been a part of that journey at HonorHealth in developing these type of treatment strategies and new technologies, or evaluation of these new technologies. But so that goes to rhythm control to maintain normal rhythm. As you mentioned, we're deathly afraid of stroke. And so blood thinners have evolved, significant advancements. The mainstay of anticoagulant therapy are drugs called the DOACs or NOACs, the direct oral anticoagulants or novel oral anticoagulants. These are a mainstay of treatment now and have largely replaced warfarin. You don't need blood tests, constant monitoring. You take a reliable dose and it works. They're still associated with risk of bleeding. And so there are further advancements, and you could explain this much better than I can, but they all work at different points in clotting cascade, right? The proteins in the blood that form blood clots or help to form blood clots. And so they're just different drugs that target different points of these cascades. And so, for example, factor XI inhibitors are being evaluated currently, and they are at least as efficacious, probably safer, at least in the early data that we have compared to the DOACs that we have now. We are investigating this in a current trial at HonorHealth. And then there are procedural strategies as well. It turns out that the blood clots come from one particular structure called the left atrial appendage, which is this little pouch that sits out from the main body of that left upper chamber, which is the perfect thing if you were to design a place for blood to pool and make blood clots form. It's off of the main chamber. It's got all these nooks and crannies, right, that blood can pool and a blood clot can form. So the vast majority, more than 90% of the blood clots come from this area. So it turns out that if you can exclude this from the circulation by putting a little plug in it, you can actually confer the same kind of protection as being on a blood thinner without having to take the blood thinner. And so mitigating those risks of bleeding that's associated with blood thinners. And so these procedures are rapidly growing. The technology is also getting better and better. We've evaluated some of those new technologies and continue to do so at HonorHealth. And so this is something that left atrial appendage occlusion has become a mainstay of our armamentarium as well.
And this is done percutaneously. It's
Also
done through a cardiac catheterization, and you just slide up and open it up.
That's exactly right. It's a catheter-based procedure. It's typically an outpatient procedure. Again, patients come into the hospital. I don't use a scalpel for any of these type of procedures, right? We're just putting catheters in and working through those catheters. And when we're done, those catheters come out and the patients go home a few hours later.
And a patient remains on a blood thinner for a period of time until that area matures.
That actually is evolving, right? So the original technologies and the way they were all evaluated were blood thinners for a time period while your own body's tissue grows over the device to completely exclude it. And it turns out that those strategies are becoming less aggressive because the technology has improved. And so with the coatings or the fabric on these devices, it's been shown that being on an aspirin and a medicine called Plavix, which is like a strong aspirin, suffices, that you don't need to be on anticoagulation. Different strategies have been to use actually half-dose anticoagulation, but there's in fact newer technologies, and these we actually have available devices where there's a new type of coating over it which promotes that tissue growth. So in fact, we might be at a place in the very near future to put the device in and then you're on aspirin right at the get-go, and that's it. So being able to stop anticoagulation immediately after the procedure.
Yeah, I think it's exciting to say that it's a hallmark of our cardiovascular research program that we're always on that cutting edge or that bleeding edge of the technology, even dating back to the earliest time when we were the first to do drug-eluting stents, and now moving this technology forward. Going back for a second to the ablation techniques, is this a thermal ablation that occurs?
It is. It turns out that there are multiple modalities, and this is part of the new evaluation or the evaluation of new technologies. Traditionally, catheter ablation has been done with radiofrequency energy, which is delivering through a catheter or through a catheter electrode high frequency radio waves, and it causes direct thermal heating. So yes, you're burning. And that's how you would eliminate these small areas of tissue. That has expanded in not just its use and the technology for that type of ablation, where we have sophisticated sensors on these catheters to monitor your contact or the pressure. We have irrigation of fluid around the catheter so a blood clot can't form on the catheter. But we have alternative energy sources to perform ablation. We have cryoablation, which is freeze burning. That is done for folks with paroxysmal atrial fibrillation or perhaps some more advanced disease by essentially pumping liquid nitrogen in a balloon, and that balloon approximate these structures called the pulmonary veins, which is where we target our ablation for atrial fibrillation. And it's even gone one step further. The newest kid on the block, which is of course reinventing a really old kid on the block, the original catheter ablation was done with an energy source called DC ablation, which is just a shock through a tiny electrode catheter. Well, pulse field ablation is essentially that more mature, where we can deliver these impulses to actually poke holes in the cells, which leads to cell death. It has some very significant advantages. It, in many ways, can be safer because of its tissue specificity. It doesn't hurt other things around the heart that can happen with other energy sources. It's very fast, so the procedure can be done quickly. And so this is actually, in a way, it's not taken over the market, but it has become a very important part of ablation technology and is rapidly expanding. And in fact, these technologies are actually being evaluated as we speak for seeking approval and demonstrating efficacy and safety. And we've been involved in some of these evaluations previously at HonorHealth, and actually upcoming we have 2 or 3 more coming down the pipe. So as these newer technologies become available and these multiple modalities become available, we have them here, either in a clinical trial or soon after approval. And that's really fun.
I mean, it's incredible because we're now talking about, at least at the technical standpoint, curing a severe cardiovascular problem that's associated with significant morbidity and mortality. For that population of patients that have recurrent disease, can you ablate a second, a third time? What's the successful capacity to eradicate atrial fibrillation if you haven't gotten it the first time?
It's a great question, and you mentioned we're curing atrial fibrillation. I'm not sure we ever cure atrial fibrillation. That's why I always say it's the gift that keeps on giving, right? But there is plenty of data that suggests that actually ablation with our current techniques is associated with a delay or halting progression, which is very powerful. The numbers for success rate are sort of arbitrary, and I'm not exactly sure if they're the most important things to even discuss. We typically say that somebody with intermittent atrial fibrillation, a one-time procedure is about a 70 to 80% success rate. Thus, folks will not have a cure, if you will, after a first procedure, and then a second procedure bumps that success rate to 90% or thereabouts. And people with more advanced disease have lower success rates, though even advanced disease, people who are in continuous atrial fibrillation, after 2 ablations, you can have a success rate that's north of 80, 90%. But it depends on what you do, and it depends on how long you're talking about, and this is an arbitrary number because it's an arbitrary definition. 1 year, no recurrence, no medications, which is great because, of course, you have to be able to compare technologies and treatment algorithms to see which one is better, but it's an arbitrary definition. I would venture to say that anybody, or almost anybody that has a procedure, has a decrease in the amount of atrial fibrillation that they have, so-called Afib burden. And all the investigation now going forward is focusing on that reduction of atrial fibrillation burden because, oh, by the way, that reduction in burden is associated with that improvement in survival. And so that's our target now. So you can imagine somebody who's in continuous atrial fibrillation, 100% of the time, they have a catheter ablation. And let's say they have a few episodes over the ensuing year that are short-lived, maybe even last an hour or less maybe. That patient would be considered a failure. That patient went from 100% burden to less than 1%. That's an incredible success. And that success is associated with decreasing the risk of stroke, decreasing the risk of heart failure, and folks just living longer.
Amazing. And so, again, for our listeners out there, it's when you're having symptoms, even if it's symptoms that people can't put their finger on, persist in seeking an answer because it may be something intermittent in this regard. And more importantly, if you're diagnosed with atrial fibrillation, don't settle back to be seen just by your primary care physician. Make sure you at least get a consultation with an atrial fibrillation specialist, an electrophysiologist who can give you advice in terms of the best options for current treatment.
I think that's exactly right.
So what does the future hold on the longitudinal basis for atrial fibrillation? Where do you see research going in the future? Where are we at HonorHealth and HonorHealth Research Institute focusing upon?
So, and this again is something I'm very proud to say, that with the support of folks like yourself in the Research Institute, we are involved with every aspect of innovation when it comes to either the diagnosis or treatment of atrial fibrillation. And so when I think about the future of atrial fibrillation or how we're going to be approaching this, well, certainly we talked about monitoring strategies. Folks are going to be diagnosed earlier. But more importantly, I think we're going to learn, you mentioned artificial intelligence or machine learning. We are, of course, getting so much data from these recordings that it's not far-fetched in any way to think that there may be predictive values for which patient is going to progress, which patient needs earlier intervention, which patient doesn't, which therapies might work better for a given patient. So this will all come from these upstream diagnostic sort of capacities that we now have in our armamentarium, and we're just beginning to see those. And we're involved in some of this investigation as well. And then we talk about treatment strategies. Sure, we think that ablation is the mainstay, and most of the innovation and technology development has been centered around catheter ablation. And yes, that continues to happen, continues to improve. The procedures are getting shorter and safer and more efficacious. And with that, that drives the indications to being targeted to a more upstream population, so earlier intervention again. I certainly can see that. I also can see, if I had my crystal ball, there's a whole host of potential treatment options that may be incredibly powerful. There are novel forms of drug therapy, direct delivery, for example, that might decrease atrial fibrillation. And going to that direct delivery for, of all things, gene therapy. Atrial fibrillation might be the first cardiovascular disorder with a real success with gene therapy. Because as you know, to have gene therapy work, you need the genes taken up and you need to actually change a certain amount of cells. And as you can imagine, if you're targeting something that's big and large and thick, like heart muscle in the ventricle, the main pumping chambers, when someone's had a heart attack, harder to get an effect. But the atria are thin. And so you can imagine if you're only affecting a small layer of cells, that might be a powerful enough effect. And that's actually been demonstrated. And so you could see that gene therapy might be something in the not too distant future for the treatment of atrial fibrillation, which would be incredibly powerful. And then as far as decreasing the risk of stroke, I think a lot of the investigation, ranging from advanced cardiac imaging to characteristics of how the heart actually contracts and moves and squeezes, is really going to give us, and already has, given us a lot of insight as to which patients really are the ones at risk for stroke and which ones thus we need to target with either anticoagulation, which of course newer drugs are coming down the pipeline, or appendage occlusion strategies, of which we have many and they continue to evolve. And so once again, a lot of possibilities, but that's what's really cool, right? When you have so many different options to treat a given disease process.
Well, and it seems from our earlier points in conversation that if you know your family's history, if you know that you have a sibling or a parent that had atrial fibrillation, as opposed to, oh, they had palpitations, which is something we often hear from the earlier generations, you can begin to imagine that those patients showing up might be able to be assessed, might be able to be intervened upon at a much earlier time point to prevent those complications and issues like heart failure as a downstream effect.
Absolutely right. And again, you know, it's all a matter of likelihood, which in fact is, for this disease, for atrial fibrillation, is driven a whole lot by age. And so sure, a 20-year-old with palpitations, probably less likely that it's atrial fibrillation. But a 50-year-old, much higher. And a 70-year-old, it's AFib until proven otherwise, and so on and so forth.
Yeah, it's very interesting, and it almost raises the question about whether or not those screening criteria need to be implemented across all of the primary care offices, not just within cardiovascular or cardiology.
Absolutely. The fact that, as I mentioned before, this is a multifactorial disease, and as such, a multimodality treatment strategy is incredibly important. And so I wouldn't be doing my job just looking at atrial fibrillation, but I also need to look at those risk factors that you mentioned, the other diseases that are associated with atrial fibrillation, and reducing their ability to affect the disease or furthering the progression. And so once again, having a, you know, since this disease is talk about pandemic, right? This is a disease of epidemic or pandemic proportions. Having systems or healthcare provider networks that employ that multimodality approach just leads to better outcomes. And I'm very proud of the program that we've developed here at HonorHealth.
Thank you to our audience. This has been Innovation Insights. Certainly, you can appreciate how innovation is driving diagnosis, management, stratification, and risk of atrial fibrillation. And all you need to do is tune in to HonorHealth and the HonorHealth Research Institute. We'll be glad to bring you that latest opportunity to learn from us from Dr. Doshi as we move forward. Thanks for joining us.